We've received one question from the public in advance of today's meeting, which we'll respond to at the end of the agenda. We have 5 members of the public signed up to join us today for the meeting, and our mirror board also receives a standing invitation. I'll start by asking board colleagues, please, for any conflicts of interest not yet noted on the register or relevant to today's agenda. I'm not seeing any hands, thank you. And please could I take you to the minutes of our last meeting, which was the 18th of March, last meeting held in public. And the matters arising, any comments or questions? Thank you very much. I will take those as an accurate record. May I turn then now to our Chief Executive, Sam Burrows, for your update. Over to you, Sam.
Thank you very much, Chair. Yes, plenty going on, as colleagues will appreciate, but I wanted just to start my update by recognising that last Monday was International Nurses Day. And this is a fabulous opportunity for us as a board, I think, just to say a huge thank you to all of the nurses who work in the organisations which comprise the Frimley Partnership. There are many of you. Some of them are sat with us today, either as a part of our board or those listening in. And I just wanted to say the difference you make to the care of our patients is phenomenal. And collectively as a board, we thank you for that. Clearly, as an ICB, we live in really uncertain times, and colleagues will be aware that we continue to work through the instructions which were set out by Jim Mackey in his letter, which was issued on the 1st of April, as a part of his day 1 letter to the NHS. That letter was wide-ranging in its brief and in its focus of attention, but in terms of what is most pertinent for this organisation and the board of this organisation, clearly is the requirement for us to make a 50% reduction to the cost base of the ICB by the end of Q3. Board members will be aware that there have been some subsequent publications, and last week we received a document titled the Model ICB Blueprint. This was helpful. It set out a number of design parameters for the future, and we continue to work collectively, not just as ICB leaders, but also with our partners in NHS provider organisations, in local authorities, and with general practice as well, to make sure that the organisational design which we set forth on for the future not only meets the parameters set out in that document, but also continues to pay really significant regard to our ability to deliver the strategic objectives that we've collectively agreed on, which form our ICS strategy, creating healthier communities. We continue to work up the options for how we would implement that, future design and delivery of ICB statutory duties and our strategic objectives clearly is the central premise here, and we've been given further clarity on the budget, which will be available to us in order to deliver those aspirations. We'll continue to keep the board appraised of that as we continue to work it through with our partners, and I'm sure that a future meeting of the board will have greater clarity and certainty, which we are able to share. What I would like to remind colleagues of this morning is that the impact of these changes has created a hugely uncertain time for the people who work for not just the Frimley ICB, but all ICBs across the country. There will be significant personal impact on members of staff, both in terms of job security and options going into the future. That means that for us as leaders and as members of this board, we need to give extra consideration to how we lead during this time of uncertainty, to be more compassionate and to have that extra moment of kindness when working alongside our people. I've noticed, and I'm hugely grateful to the continued contribution of all of our staff and the manner in which they are leaning into this challenge, and the levels of professionalism which are being shown by colleagues at such a difficult moment of time is really noticeable, and we are particularly grateful for that. Outside of change and transition, clearly our day job remains, and we are keeping a significant core focused attention on delivering the improvements, change and access that our residents rightly expect from us to healthcare services. We're continuing to work through our strategic and operational priorities for the year ahead. And the plan that we put in place for 2025-2026 is both stretching and ambitious in terms of improvements, both to access to services, but also our ability to do that within the financial envelope that's available. I think we should be positive, however, about where we currently find ourselves as we come towards the end of the second month of this financial year. Out of the 10 million people that live in the southeast of England, if you're lucky enough to live inside the Frimley geography, you are more likely to see a GP inside 24 hours than any other part of the southeast region. That's a phenomenal achievement, and a huge thanks to our colleagues who work in general practice day in, day out, making extra capacity available to see local people when they need to see a doctor or a member of practice staff quickly. Thank you for the work you're doing in that space. I know it's hugely valued. For urgent care, more than 3/4 of our residents, when they need an urgent care appointment, whether that's in one of our 2 excellent emergency departments operated by FHFT, or inside our urgent care centres or same-day primary care services, they are seen within 4 hours. And I think, again, that is a really, really solid achievement, and something where I know we want to continue to improve, but great for our population as a whole. We continue to improve waiting times for elective care and elective surgical procedures, and our ability to offer treatment within 18 weeks of referral also continues to improve. And we are doing all of this within the money that's been allocated to us by government to achieve these aims. And I'm really pleased to be able to tell the board that for the year that we've just finished, subject to audit, in 24-25, we delivered all of our priorities within the money available, and actually delivered a very small surplus as well. I just wanted to say a real thank you to members of the board, whether they're ICB leaders or leaders of partner organisations. This is a really tough time, but we continue to deliver for our population, which is what we're here to do. And I wanted to make sure that was fully acknowledged today. Nothing else from me, Priya, but happy to take any questions that board members may have.
Thank you very much, Sam. Can I open now to comments and questions from members of the board? I know we will be picking up a number of those issues as we go through our agenda this afternoon. So let's move then to our next session, outstanding use of resources, and we're starting that with our 25-26 planning and delivery. So over to our Chief Financial Officer, Rich Chapman. Thank you, Rich.
Thank you, Priya. So I have provided a paper for the board which describes 4 key mandated deliverables for the NHS for the 2025-26 financial year. Those cover kind of theme areas along improving access to timely care, so ensuring patients receive prompt access across A&E, elective and mental health services, increasing productivity, where the national requirement is a 4% improvement in productivity whilst reducing the cost base by at least 1%, living within allocated budgets, which our plans describe that we will do for the 25-26 financial year, and driving reform and implementing innovations and reforms to enhance service delivery and efficiency. All of those, so the plan we have submitted delivers all of those things. There are some key risks to the health economy, which I'm going to break down. So Sam's given us a very positive picture. My job is to point out what the risks are for what lies ahead. So key risks identified within the planning process include the delivery of the total efficiency plans across the ICB FHFT and a remaining residual system gap, which was unidentified at the point of plan submission. There has been a consultation on the NHS standard contract, and initially the consultation gave NHS commissioners more material levers to enable the system to manage its elective activity to the targets required within the budget available, which did not survive the consultation. And so there is a new mechanism in there which will require resource and the development of contracting intelligence to enable the system to utilise the levers that are now available to us to manage variable activity to within affordable limits. Length of stay at FHFT remains a significant challenge, and we will need to continue our efforts in the system space to reduce the demand for acute beds. And of course, there is always a risk that remaining savings targets, the delivery remaining savings targets, may impact operational delivery, which we have a mechanism in place to ensure that we are carrying out impact assessments as we make decisions on how to save money. Then on top of those, so all of those planning risks, I think, are ones that apply to the NHS nationally. There are some specific environmental risks relating to Frimley. So it's a highly challenged environment in terms of the demand that we're required to service and the resource that we have available. And we are required to do so while safely operating a RAC hospital and ensuring the delivery of a new hospital within the Frimley system, which certainly creates additional risk to our day-to-day management of the system in terms of management bandwidth availability. And then finally, a newly emerging risk is the requirement to reduce ICB operating costs and provide a corporate cost during the course of the year, which again has the potential both to consume management bandwidth and to cause distraction for the personnel who are charged with delivering the plans. In terms of our approach to delivery, so the system is working very rapidly to institute an enhanced financial recovery program that differs from a perhaps a more, in inverted commas, traditional turnaround approach, in that we are ensuring that we have explicit safeguards to prevent the enactment of short-term financial recovery actions which have the potential to undermine the long-term system transformation and long-term sustainability of the system and delivery of the new hospital. We have a longer-term transformation plan. It's well developed in terms of opportunity identification, and the next steps there are formally to embed a jointly owned delivery mechanism across the system partners, and boards are being asked to approve that transformation plan at meetings this month and early next month. So in summary, as a system, we remain absolutely committed to the ambitions set out in the plan as it is submitted. Board is asked to note that the actions set out will not shift the ambitions of the plans, but effectively are designed to reduce the level of risk inherent in them. Happy to take any questions on any of that, Chair.
Thank you very much. Let's start with Sajid. Thank you.
Thanks, Rich, and congratulations to you and the wider team for hitting the surplus that Sam referenced last year. So it was a great job considering where we were at the beginning of the year. In terms of risks, just wanted to highlight another potential risk, which is the NHS 10-year plan, and when that gets published in June, is there a risk that will accelerate new things that we haven't currently factored into the existing plans that you and Sam mentioned, which are already very, very full and very, very challenging?
So obviously we need to see what the detail of the 10-year plan is when it comes out, but my anticipation is that the strategic coincidence between our system's strategic objectives of minimising health inequalities, maximising healthy life years, the DARSI recommendations, and our requirement to deliver a sustainable system all overlay one another. So we need to minimise health inequalities in order to reduce the demand for acute beds, in order to make the future system sustainable. And similarly, the DARSI recommendations of hospital to community, analog to digital, and treatment to prevention all align strategically. So I wouldn't anticipate that it will derail or change direction on anything that we are currently planning to do, but we need to wait to see the detail.
Very helpful, thank you. I think that sort of a core direction is really important, isn't it? And as you say, Sajid, we have to be mindful of things that may come in as additional or different. Mark, Sam, do please add if you feel that there's anything you'd like to in relation to the transformation programs and that direction of travel for the 10-year plan. I know that's been very high on your minds in terms of the way in which we've worked with partners to create the nucleus of that transformation approach. Okay, thank you, everybody. I'm going to move us now to mental health and the independent homicide review. And Sarah Bellas, our chief nurse, will take us through this item. Thank you, Sarah.
Thank you, Priya, thank you. I've set out quite a lot of detail for the board within the slides, which I won't go through all of it, but just talk about the pertinent points, as this is actually something that we have been asked to deliver at a public board, so it's really important that we take this. You'll recall that I brought this to you initially in February this year with the plan for how we were going to look at it. And this was following the manslaughter of 3 members of the public in Nottingham by Valdo Kirkane. And both NHS mental health providers and ICBs were asked to review and the recommendations and provide assurance in this public way. So we have worked with our mental health providers, Berkshire Healthcare Foundation Trust and Surrey Borders, and our neighbouring ICBs, because both of those trusts are within other ICB boundaries, and we've tried to work consistently across to review their plans and to provide the assurance as required. If we move to the next slide, please. Thank you. This slide talks about how we and our other system partners work in respect of mental health care treatment and risk management, and the way that we promote multi-agency working and the groups that we attend and our partners attend in order to do this. We have a patient safety level forum with participation from our main commissioned healthcare providers, which is a key channel for learning improvement work for patient safety responses as well. Want to move to the next slide? Thank you. So this slide talks to the plans that BHFT have submitted. They have assured themselves, and this has been to their public board, around their plans to meet the requirements for this. Whilst they haven't developed a segregated team, they have a clear plan for managing patients in this way, and they are assured, and we're assured that they can do it. We recognise that there are challenges that remain, and we'll continue to work on those challenges as described. Do you want to move to the next slide? Surrey Borders are continuing to work on their plan, and this is going to their public board meeting in June 25. They have worked with us, so we have a clear understanding of what they're going to do, and we're confident that once they've taken that to the board, that we'll be able to bring that back and that we'll be satisfied with their approach. We go to the last slide, and then that's just the assurance planner for us to see how we're doing that. So we will be bringing that final piece back following the Surrey Borders meeting. Thank you. Really, it's for questions, Priya, because I think it's all detailed in there.
Thank you. Did any partner colleagues want to come in and add anything? Graham, come in.
Yeah, I just wanted to echo what Sarah had said, that we've got our paper going to public board at the end of the month, and it does step through our assurance on the 4 areas. So that will be available, and how we've worked with the cohorts and some of the digital changes that we are going to be making to make sure going forward we're well sighted on this community and can ensure we keep them safe. So I just thought I'd share that.
Thank you very much, Graham. And Alex.
Thanks, Priya. And just to add to the public board assurance for people watching or listening, you can go to our website at Berkshire Healthcare and see the board paper where there's the detailed action plan that's provided the assurance that Sarah's spoken about. Thank you.
Thank you very much. Any other comments or questions? I think thank you to Sarah and colleagues, and we've noted as a board the steps taken and the approach being taken. So thank you very much. Let's move then to our work as a region, as the ICBs across the South East region. And we're looking next at the terms of reference for the South East ICB and NHSE Joint Committee for Delegated Commissioning. This is a key part of the approach that we have to population health, and so it's a very important element. So over to you, Caroline.
Thank you, Priya. Board colleagues, I'm asking you to note the terms of reference now for the establishment of the joint committee across the 6 ICBs in the South East, as Priya says, for a range of areas that have been where we've had delegated commissioning functions. The establishment of this committee will enable benefit to be realised across the South East through the 6 ICBs, particularly in areas such as specialised commissioning, the work to prepare for the delegation of immunisation and screening to ICBs, and work ongoing around podiatry, optometry and dentistry. Just drawing your attention to the schematic shown at figure 1. I think that's a helpful way of understanding how the 6 ICBs with the South East region leadership team have created and agreed the committee, and starting to signal some of the other opportunities around at scale strategic and collaborative commissioning, such as ambulance and emergency care. Happy to take any questions. The detail of the terms of reference are attached, and all 6 ICBs are signing those terms of reference off in May board meetings. So hence to note the joint committee terms of reference, please.
Thank you very much, Caroline. This is an important element of working at scale and being sure that we can do that with colleagues across our region. So thank you for all the work that has led us to this point. Thoughts, questions? I know that we have been working on this for some time with colleagues across the region, and that our system has considered this in some detail and has some experience of having taken responsibilities in this space as well on behalf of neighbouring ICBs across our region. So thank you. Sam, would you like to come in?
Yeah, thank you. I don't want to prolong the discussion unnecessarily, but I think it is just worth noting that clearly what we do with the Joint Committee is more important than the establishment of the Joint Committee. And just to reassure colleagues on the board, there is significant work happening in the background, particularly with the current team who is working on specialised commissioning in NHS England across the South East region around what is the strategic intent for improvement, for transformation, for access for our population to specialist services as delegation continues to take place. And as we use the opportunity the Joint Committee gives us to take the best decisions for the benefit of our population as a whole. So I think it is important that at a board meeting of a future juncture that we start to bring through a bit of that detail for board members to see, so that you can be assured the Joint Committee is really getting into the right work areas around the improvement of specialist services as a whole. But it's a really positive development, I think, for commissioning at scale in our region, as you say, Priya. Thank you.
Thank you very much, Sam. And could I have confirmation then and support for the joint committee terms of reference and the way forward? Thank you. I'm seeing nods on screens. Happy with that, and even a few thumbs. Thank you very much. Let's move then to policy, an area where trying to achieve consistency and fairness, therefore, is so important to us. So thank you for the work that's gone into all of these policy approaches. I'm going to hand to our Chief Medical Officer, Lalitha Iyer, to take us through this IUI policy. Thank you, Lalitha.
Thank you, Chair. So as you said, this paper outlines the engagement and the next steps that are going to begin further to this board previously approving the alignment of the intrauterine insemination, which is one of the treatments for people suffering from subfertility. And this is a provision to our population to ensure fairness, consistency, and legal compliance. So engagement will take place to understand the impact on those affected and ensure that their voices are heard. Our comms teams will engage with those most likely to be affected and is likely to include focus groups, discussion with relevant charities, local representatives, local authorities, and health organizations. The feedback from this engagement will help us shape future decisions. And in order for us to have a targeted, proportional engagement approach, the team has proposed a timeline that is attached in the paper. The entire timeline is due to be completed with a possible go-live date of 1st of September. The paper outlines the details of who the groups might be and so on. We will also ensure that good and adequate and appropriate transitional arrangements will be put in place for those who may have already been referred and are in the system once a go-live date has been confirmed. And the guiding principle for this will be a principle of no disadvantage to the person who has been referred. So I think I'll stop there. There's more detail, obviously, in the paper.
Thank you very much. And you've set this as the first part of the overarching coherent policy approach in relation to fertility for the South East region, so that it is clear for patients that how things are managed and that there is equity in terms of how fertility is addressed. So thank you for that.
Absolutely.
So comments and questions on board. Grateful for the detail of that and the staging that you've outlined. Can I ask then for board support for this approach to creating that clarity? I think I speak on behalf of all of the board in saying that we welcome the South East region looking at this and creating this clarity at pace, because it will be very helpful for people to feel confident and trusting in the services that they can access and that they receive. So thank you for taking that forward into the regional board too. Okay, I'd like to move us then into our current year performance reporting. And I'm going to hand over first to our Chief Nurse, Sarah Bellers, to look at the quality and performance report with us. Thank you, Sarah.
Thank you, Priya. Actually, I'm going to hand over in true partnership style to Gronya, as she is a member of our board and she is living and breathing the Bracknell Send inspection far more than any of the rest of us, and it's probably she'll give a better account. Thank you, Gronya.
Yeah, thank you.
Thank you very much, Gronya.
Yeah, I wasn't intending to go through every slide, so just very quickly. So people may know that we were last inspected at the end of 2021. During that period, we had 32 areas in need of improvement, and 9 of which were areas of significant weakness. So we've been formally monitored by Department of Education and NHS England, and we were the first in our area to have the Send inspection under the new regime. Now, the new regime is different to the previous one, and it does look helpfully through the lens of the child and young person. So unfortunately, whilst we had made significant strides, and that was mentioned at least in part in the inspection results, we hadn't made sufficient improvement that was visible on the outcomes and impact on children and young people. And indeed, because they're looking backwards over a period of time, through the lens of the child, there was a lot of inconsistencies. The education, health and care plans in many instances did not identify the needs of the children in a coherent way. The Send inspection is one of the areas that people will know. Both the ICB and the local authority are held jointly accountable for the delivery of that, and hence both regulators, CQC and Ofsted, are involved, coming together. And it was a very interesting for people to be involved in it. It wasn't a stone unturned. Lots of discussions. It looks at the whole system. It's not just Send. So it looks at continuing healthcare, spoke to GPs, etc. So it's that whole system. Now it comes together to both identify the needs of children and young people, but also then effectively plans and then commissions services to meet those gaps in need and provision for the children, and how we then coordinate and wrap around the children and families while they're waiting for services, but also in the various different component parts of that system. Now people will know that we've done a huge amount of work in a lot of the planning for example, children and people integrated therapies across the whole of the East Berkshire, but that new contract isn't up and mobilised yet. So whilst there's a huge amount of work from an inspection lens noted, but unfortunately children are not benefiting from that yet. So the lens was very much about that. And so we are, as a system, we can only apologise that we've not been able to secure significant improvement since the last inspection in the actual experience for children and young people in there, and the impact that's having on their families too. So we do have to accept that, which we have. In terms of that reflective piece, I think we've all worked really hard post-inspection and during the inspection period to understand what is it that we need to do differently as a system. And so moving forward, we've been working very closely together. In terms of the position going forward, we have to produce something called a priority action plan. So whereas we had 9 areas of significant weakness previously, we have 3 areas equivalent to that status now, and we're required to submit jointly a plan, and that is on Friday 23rd. So we've tried to engage and involve people in the development of that plan, including our colleagues from the Parent Carer Forum. So representatives from the Parent Carer Forum have been involved because we've had to draft that in real time. We've involved elected members and the whole raft of colleagues, and across the whole system. It's very much something that we've done together jointly in real time. So that's been really helpful, and we continue to do that. In our new environment, what we are going to do in terms of strengthening that oversight and independent review of our system is we've secured an independent chair for the set up a SEND improvement and assurance board. We have an independent chair who's linked to sector-led improvement for the South East. We set up a range of subgroups as well to move forward the 3 areas of that are identified within the areas of priority action. Those 3 areas all have subgroups, and we're having a subgroup also looking at the implementation of our system SEND strategy and the development of the new one. In terms of political oversight, because we know how important SEND is in terms of for all areas of our community, our political leaders are very interested. So we've also set up as a local authority a executive advisory group who will work with our portfolio lead, who is Councillor Bailey, and there'll be complete openness and transparency. All of the documentation that we're going to be submitting to NHS England Department for Education will go through that group. They will have full access to all of the paperwork through our improvement board as needed, and they'll be involved as well in the development of the new strategy. We've also engaged with our scrutiny colleagues within the local authority, because obviously they're very interested in that. And going forward, we have to have a very different approach to communication engagement with our children, young people and their families. So I think historically we've done a lot of that work through the Parent Carer Forum, and recognise that we do need to think carefully about how we go and meet with families, children, young people in those environments that they're receiving services directly. So there's lessons learned already about what that might need to look like, and our scrutiny colleagues are also going to support us in them reaching out independently to parents to help develop what that communication engagement plan is going to be. So we've got a range of views, which is only going to strengthen our collective response. All of the work that we've done since during and since the inspection has been joint. So all of those meetings that we're holding with everybody, whilst the capacity is very stretched on the SEND side, our senior leaders and others from the ICB and our partner agencies have also been actively engaged in that process. So a real commitment to working through those improvements. With the foundation work that we've undertaken, we do expect there to be improvements that do start to be shown, especially in access to integrated therapies. So the contract that I talked about, a lot of time and effort spent on identifying the need, specifying the requirement going forward, and then getting that in place through Berkshire Health Foundation Trust. So those revisions and the reshaping of that hopefully will start to feel different to children and people and families. But it's really important that what we're committing to in terms of our detailed plans, that we continue to work that through and deliver it, and we have evidence of delivery and evidence of impact and outcomes. And I'll stop there, Sarah. I didn't know if there's anything else you wanted to add.
No, thank you, Grania.
Thank you very much, both. Really helpful, and your reflections there about how we get that voice of the young person in there in different ways. That is going to be very helpful for us, isn't it, across all of our system working. So that insight is really helpful. Can I ask colleagues for any comments or questions in relation to that, or indeed anything else in terms of the performance and quality report that you have? Thank you. I will move us then to our finance performance report and to CFO Rich Chapman. Thank you, Rich.
Thank you, Priya. So the paper, can we move on a slide, please? So the papers describe the month 11 position. Now, this is a little bit out of date, but at month 11, we were showing an adverse variance against plan of £700,000 across the system. As Sam reported earlier in his chief exec's report, we, subject to audit, finished the year with a slight surplus in the ICB, and we delivered our required break-even position across the system as a whole. There have been particular pressures during the course of the year, both demand driven, which you will see in the performance, but also comes out in the finances. but also inflationary driven, particularly in the areas of prescribing, both on the ICB side in community and on the trust side. And part of the demand drive of our cost base as well is new nice technology appraisals coming online, which will remain a risk for the foreseeable future, on which we need to stay sighted. Can we move on a slide, please? So this describes the financial position as at month 11. I don't want to dwell on it. It is, as I say, a little bit out of date. If we move on one more, that will be great. Thank you. So this slide reports the ICB's capital expenditure for the course of the year. You will see that we spend about £1.2 million, of which about half goes on GPIT, and the remainder effectively goes on general practice premises through the course of the year to maintain the quality of premises. We move on one more slide, please. And again, and this describes, so we've had a particular performance issue during the course of the year in the cancer 62-day wait. Dermatological cancer is a particular issue. It is subject to ongoing recovery action across the trust and the ICB, and the 4-hour ED time, I think, recovered towards the end of the year, but we didn't hit the 78% target. Our plan for 25-26 encompasses recovering to that 78% target during the course of the next financial year. If we move on one more, please. And this is, I guess, another point, harking back to what Sam said, is the excellence of our responsiveness to requests for primary care appointments. So we are delivering the quickest access to primary care in the southeast, with 84% of appointments being within 24 hours and 90% being within 14 days, despite the demand pressures throughout the system. We are under the England average on the face-to-face appointments, and we believe that to be actually a direct correlation, that the more you are able to operate virtually, the faster you are able to see patients, and that remains a source of pride within the system, that we are delivering that rapid access to primary care. If we take slides down, I'm happy to stop there and to take any questions.
Thank you very much. And Rich, do you have anything you can share yet in terms of how we're starting the year? Really noting your very helpful comment about, we're trying to achieve rapidity of people being seen, and so some indicators don't necessarily perform well, even though actually the outcome is exactly what we're trying to do, which is to make sure that people can be seen promptly. So how have we started the year? So
I don't have a month one report that's has been validated sufficiently to share in a public space yet, Chair, but as soon as that is available, it will be shared.
Great, thank you very much. And Sajad, come in.
Just question, Richard. Broadly across the nation, there seems to be an underspend on capital budgets, and I noticed across the system there was as well in Frimley, if I've read the numbers right. Is that something that's been looked at for the following year? Obviously, with the new hospital programme, that becomes a bigger challenge.
Yeah, I think historically there has been an issue with commitment of capital, and part of that is process. Particularly as we went through the pandemic. We have planned for the future, and I know the indications from government are that we will have a much more stable kind of 3-year forward view of what resource will be available to us, which would facilitate delivery in a much more managed way than has been the case in the past.
Thank you. Come in, Prash.
Thanks, Priya. I mean, it was really just to your point and obviously Rich's point, and say, Rich, thank you very much for presenting the quality, and you're absolutely right. I just wanted to give a little bit of colour, a little bit of flavour really to those statistics, and this is from general practice at the coalface, so it's anecdotal to a degree, and some of that qualitative information will be useful, but for the public on the call, I mean, we are finding from our patient feedback that even though face-to-face consultations are becoming, I guess, less traditional, but the flexibility and the rapidity with which we can answer a patient's question, because access is not just about sometimes the presentation of conditions, it's a variety of things in primary care. Primary care is so broad. So our ability to do follow-up calls, our ability to process and prioritize education, or in fact, when we are delivering reassuring news, we have the ability to then put education and prevention onto that. Now, if you did that all through the traditional lens and model of face-to-face consultations, I think what you'll get is not just a bottleneck, but actually the patients themselves wouldn't necessarily appreciate the fact that they're busy. And actually what they want to be able to do is have rapid phone calls or rapid texts, because they sort of know where on the pathway they are at. So the ability to be flexible is what shows our ability to be available. It's a shame that in some ways the dry statistics don't recognize the fact that we are certainly hitting targets well over and above because of our ability to embrace the technology, but also for our patients to embrace the technology, which then sometimes makes another dry sort of siloed statistic, it makes no sense, because there's a contradiction in terms there, because the whole thing is part of one whole flexible process rather than individual recognizable thresholds. So it was really just to give a flavor to that, Rich, that it's the flexibility that my patient population is seeing. So I think they are happier that they're being seen quicker and that they have that access, despite what the media often says. But they also understand that that does come at a little bit of cost, that sometimes that's got to be done remotely or without the traditional model. And I think that's just important to pepper that statistic with a little bit of storytelling around it. Thank you.
Thank you very much, Prash. That insight is really helpful to flesh that out. And I know that in our transformation work, Mark's leadership around that, we're looking at the triangulation, aren't we, of performance figures, so that we can be sure that what we're really tracking is the outcomes that people want to experience, and that's what we'll be giving focus to. So thank you for that. Let's move to our workforce performance report with our Chief People Officer, Caroline Corrigan. Thank you, Caroline.
Many thanks, Priya. I won't go through every slide. So if you don't mind, Sam, we'll just move on a couple, please. The headline workforce metrics, the next slide, thanks, is the time lag. You'll see we're showing month 11 data at this point. I'd just refer to patterns at the moment, particularly on temporary staffing. The pattern of being under plan on agencies, slightly over plan on bank, is a pattern across the southeast, so not unusual at that point in time. Moving on, please, Sam. I'm just going to connect just a moment for us as an employer. So our ICB workforce remains pretty static in terms of numbers at 375 whole-time equivalent, or 448 people working for the ICB, with low turnover and low sickness absence rates. Moving on, the next area of the reports, that's some of the detail on our ICB workforce metrics. And again, please, Sam, the area I'm just going to hang in for a moment is the temporary staffing collaborative, related to the pattern of performance in our system. We not only host the collaborative, I'm SRO for this, and the executive leadership from Julian Ems as BHFT Chief Executive. So you'll see, if you've had time to absorb some of the data in this report, we've got a full year data point there, which shows the 27 trusts across the southeast, including The 3 provider trusts obviously represented in this data, achieving a 23% reduction year on year on agency reduction. So whilst the pattern was showing increased bank, there was also a minus 9.2% reduction in bank usage over the same time. The Southeast, and of which our 3 trusts particularly reported here, achieved below the ceiling cap set at 3.2%. We achieved 2.6%. So a good strong year's performance on temporary staffing, collaboration working really well across the Southeast. The programme most recently was presenting nationally on the BI dashboard tools that we've built across the Southeast as a way of tracking measurement and performance on temporary staffing. Focus for this coming year signed off by the programme board on medical staffing in particular, and my thanks to again FHFT colleagues as again strong engagement on that particular area of work, with 11 trusts including FHFT collaborating to accelerate work in that area in particular. Just moving on, I won't go through all of the other highlights, just to say as an ICB, as an employer, if we can take the slides down now, please, a focus on our OD programme, maintaining that focus as we shift now into more of a change and transition environment. A lot of work being done with our line managers forum, the wider leadership forum, so the senior management of the organisation, to prepare for change and transition through the year. Thank you, Priya. That's my highlights from that report.
Thank you very much, Caroline. Any comments or questions in relation to the workforce report? And could you take us, Caroline, now to the board assurance framework, which is an updated and in view of our current circumstances? Thank you.
Absolutely, thank you, Priya. So the report profiles the position on our board assurance framework, reminding and maintaining our strategic objectives as the board have previously supported. We highlight that we will be taking the model ICB blueprint and reviewing that, considering that, and overlaying therefore to update our strategic objectives and associated risks. At this stage, just flagging to the board the trend around controls and also the risks that are out of appetite, particularly 2 of the strategic objectives within risk appetite, and 4 continue to sit outside of risk appetite, related particularly to the areas of leadership and culture, resource, starting well and living well. We will be providing further update work to the board as we review the BAF, the Corporate Risk Register, and also aligning the integrated risk groups assessment. So at this stage, just asking the board to note that we will be reviewing and updating our risk appetite and statements, given the changes particularly to our environment, and in particular the work around the requirement to meet reductions in 50% reductions in our costs, and the development of the integrated care board blueprint.
Thank you very much, Caroline. Any comments and questions in relation to the BAF? We will continue to see updates on that. Thank you very much. I will move then to questions from the public. We have had one question in advance of today's meeting, and that was, could we have a more detailed report on what has been achieved and what constructive action is taking place to move the negotiations forward with the trustees of Linwood and any timeframes agreed? So on this, the ICB has secured a package of funding to deliver a health development in the Ascot area. The site for the development is not finalised, as we understand that the originally intended site is in the final stages of sale by the current owner, and it's not possible to progress any negotiation on the purchase of that particular parcel of land pending completion of that sale. So all possible alternatives will be explored by the ICB in partnership with the Royal Boroughs Council to utilise the funding secured to deliver the development. So thank you very much to that for that question from our member of the public, and we're really very keen for questions also in the future, so thank you. And thank you to members of the public who've joined us today and to our Mirror Board too. May I ask colleagues, is there any other business today? I am seeing shakes of the head. As we close today's meeting, I just want to say a thank you to all of our people across the system, leading well through this period of reset and with the integrity and kindness that I think we've come to really value and expect now as part of the way that people work across the system. And I think also very clear that we are not going to lose sight of our in-year delivery and impact, because that's what we are here to do, made possible by our committed and talented staff and by the strengths of our partnerships and our relationships. So thank you, everybody. Thank you for the work that will go on in between our board meetings, and we are next meeting in public on the 22nd of July at 11:30. Thank you very much, everybody. I'm going to bring our meeting to a close now.
Thank you, Priya.
Thank you, Priya. Thanks all.
Thank you.
Thank you all. Bye-bye.